All right, we're going to go ahead and get started. Hello, everyone, and welcome to another CortiCare webinar. This one on not all spikes and sharps are epileptic. It is hosted by our very own Dr. Navita Kaushal. She's been with CortiCare for almost 5 years now, 10 years in the neurodiagnostic field, 14 years of teaching of anatomy and physiology, and another 10 years of research on the effect of sleep deprivation and hypoxia on the progression of neurodegenerative disorders. She has her REEGT, RNCST, and ACLTM, and a whole bunch of other things. But she is a great teacher and provides a lot of great information. So without further ado, I'll hand it over to Davita.
Thanks, Brad. Good evening, everyone. So today we're going to talk something that stump all of us, right? Whenever we see something sharp, something spiky, is it epileptic or is it just something else? So we will talk about this whole presentation. During this presentation, first, let me disclose, I have nothing to disclose for this presentation, except that all the samples that I have today is collected from the articles which are available on the internet. Some of them I found through PubMed and some of them through just by going to Google. The outline is, let's talk about overreading of EEG, how it leads to misdiagnosing a patient. And what is the criteria? If we are overreading, do we need to understand the sharp and the spike that we are seeing if it is epileptic? So what is the criteria to define a sharp? And then what are the patterns out there that confuse us, which resemble sharps and spikes? And in the end, we will have a little bit of fun with question and answers. Okay, so we know the hallmark of epilepsy, the hallmark pattern of epilepsy is sharps and spikes, or we call them interictal discharges. Funny thing is, when I was reading these articles, I came across these two statements. Reading EEG is still more of an art than science. So the art of recognizing if a pattern provided to us is a real sharp and a spike. And then not too long ago, Tatum et al. Writes in the journal that visual analysis, imagine it is a digital word, ChatGPT, and there is AI out there, right? So still it is said that visual analysis is a gold standard in clinical EEG. So no matter what the software's out there, what the algorithms are being developed to read EEG, visual analysis is still a gold standard. That should be comforting to many of us, right? All right, so these are the epileptiform spikes. Some of them are low voltage, some of them are high voltage. They come with slow wave. They can be blunt. They can be biphasic. There could be a double spike in it or a triple spike. There may be a sharp spike. So I'm not going into the duration of spike and sharp, distinguishing between a spike and a sharp that we have already read millions of times, 70 to 200 milliseconds, and we are defining spikes and sharps. I'm just going to mute my phone. Sorry about that. Okay. With the new terminology, like the term we used to use, polyspikes, polyspike and wave. So there are some plus factors when we are defining interictal discharges. Again, not dwelling into that, we will stick to our presentation of if it is a spike or a sharp. And then, of course, these spikes and sharps patterns, they can be normal or they can be abnormal. It's easy to recognize when we see an abnormal. But when we see something which is questionable, are we really calling it normal or we are calling it abnormal and overdiagnosing the patient? So what happens with overreading? Believe it or not, 25 to 30% of patients which are seen at epilepsy centers, they do not get better. They do not get better, right? They do not have epilepsy. So they who get diagnosed with epilepsy based on a pattern in their EEG. There is not one. There are multiple articles out there which say that up to 30% of the patient that the physicians see in the epilepsy center, for drug-resistant seizures, they do not have epilepsy. So what could be the reason for that? It could be they have a resistant form of epilepsy, but there is an article out there which says that 282 long-term EEG studies were reviewed, and not even one study mentions that presence of normal variants. So all those patients, if they got diagnosed with epilepsy, was it a misdiagnosis? And there are articles out there, there is research conducted, there are lots of review articles which talk about harm from over-interpreting benign signals. So it's a very well-documented fact that patients are getting misdiagnosed because of overcalling a given EEG pattern. Now, it's unclear how do we prevent harmful effect of underinterpretation of any of those signals. So that is, I guess, a topic for some other presentation. Okay. So what happens when a patient get misdiagnosed by over reading the EEG? The very first thing is their driving privileges are provoked. Now they have very limited career choices. They cannot go and do, let's say, a window washer, right? Or a bus driver. So their choices get very limited. And not to say all the side effects of the anti-epileptic drugs that they are put on. And of course, whatever the underlying cause, that goes unnoticed, that goes untreated. So why are these patterns getting overread? First is lack of proper training, not able to have an exposure, right, to EEG out there. Then, of course, fetishizing phase reversal, that any big and spiky waveforms. And then the definition is too vague. Most of the time, we learn to read EEGs from word of mouth, right? Our physicians, our senior techs, they teach us, and we learn it. So if the definition was too vague, if it is not explained to us, this is a sharp, this is a spike, that's the reason. Oh, this is not a sharp, and this is not a spike, and this is non-epileptic. If it is never told to us, why is that so? We are going to overread. We are going to misdiagnose our patients. I have a picture of a handbook of EEG interpretation, just so you know. The neurologist who wrote that book, they mentioned that another cause of overreading is trying too hard syndrome. So what is that? I'm going to read it. They say that this is a term used in field of neurology to describe a situation where a clinician might interpret EEG readings by overemphasizing seemingly sharp or spiky waveform, potentially diagnosing epilepsy when it isn't present, simply because they are overly focused in finding abnormalities, even if the findings aren't clinically significant. So trying too hard syndrome, I guess it's quite a dangerous one compared to the rest of the bullet points that I presented. So what are the patterns which look like interictal discharges? There are some artifacts which are very sharp and spiky. And then, of course, there are some benign EEG variants, which is a major focus of this talk, to differentiate between IEDs and the variants. All right. So this is a list of physiological and non-physiological artifacts out there. The ones which are highlighted with yellow are the ones that produce sharp morphology. So we are not discussing artifacts, just give you a list that these artifacts do look like sharp and spike, and it is really important to identify them, recognize them, and mark them appropriately. But we're going to go into, first, let's talk about what is a sharp and what is a spike, right? How is it defined? Yes, There is a 6-sensor space criteria, which is proposed by International Federation of Clinical Neurophysiology. So what does it say? So instead of reading all this, let's have a visual aid for that. Okay, so these are the 6 criteria, 1 through 6. Let's go one from serial wise. The first criteria is when the morphology is biphasic, it's sharp and spike. Number 2 criteria is the duration of the waveform is very much different from the background activity. Number 3, there is waveform asymmetry. Number 4 is there is an aftergoing slow wave. And 5th is there is disruption of the background. And number 6 is the field distribution. So the field distribution, it says, we know that the field distribution is there is a negative and the positive potentials on the scalp. And there is a source of the signal in the brain, which corresponds to the radial, the oblique, or the tangential orientation. So it's when we learn about generation of EEG in the neurons in the white matter. So we talk about field and distribution. So the 6th criteria is the distribution of those signals. Now, out of these 6, how many do we require to define a pattern, spike, or a sharp? You have to have number 1, 4, and 6. That means a sharp or a spike morphology and a aftergoing slow wave. And of course, there has to be a physiological field and distribution that you should be able to recognize in the EEG. Okay, so if not these 3, so these 3, 1, 4, and 6, definitely it is a spike or a sharp, right? It is an interictal discharge. If not these 3, you should have at least 5 of the combinations in any form. 5 combinations will define that the pattern you are seeing is a sharp or a spike. If it is missing, if one of those is missing, it is not. So there are benign variants. Some of these benign variants are sharp. So what is a benign variant? It's a normal pattern of an uncertain significance. So the previous list, I categorized into these 3. We have sharp variants like wicked spikes, small sharp spikes during sleep, 14 and 6 hertz burst, 6 hertz spike and wave burst. Then there are some rhythmic variants which are sharply contoured. They are not pure sharps and spikes, but they are sharply contoured. They are rhythmic. Mu, RMTD. Then you have subclinical rhythmic electrographic discharges or SRIDA. And of course, the posterior variants, which are lambda and post. So all these, many a times we have made us think, okay, is it real? Or it is just an artifact, or it is a benign variant. Let's go over lambda and post first, because they are very different from the rest, right? Lambda, we all know it is present during awake state, and we see in a patient when they are looking around, they are scanning an object, usually the lateral scanning of an object, usually reading, right? It is bilateral, symmetric, and it disappears with eye closure. So if you are still seeing sharps at the posterior channels with eye closing, you have to start thinking those 6 criteria, right? Going to posts. Posts are like lambda, but they are present when the patient is drowsy, even during stage 2 sleep. They are never ever present during REM sleep. So they are surface positive, semi-rhythmic runs of 4 to 5 hertz. So here is an example. So your lambda is for looking. When the patient is awake with eye blinks, reading, scanning an object, you would see these sharps in the occipital channel. And during sleep, the sharps that you see at the occipital are called posts. So you see presence of spindles and some K complexes here. So we can easily sort of say these are the benign variants. These are non-epileptic. These sharps continue to present in REM sleep, then you have to start re-evaluating them. Mu rhythm. This is a rhythm from the central region of the head. When the patient is awake, and when they close their eyes, it does not go away. So lambda is in the occipital region, mu is in the central region, and it kind of sometimes bleed into your parietal and sometimes into the occipital, but most of the time it stays in the central and the parietal region of the head, right? Because it's originating from the motor strip. And if you are not sure, you can ask the patient, hey, can you move your hand or your leg? Usually the hand, right? And if you are seeing that the rhythm disappears, that confirms it's a mu rhythm. Here is another example, just so you know, to figure out if this pattern is epileptic, you ask the patient, can you move your hand? Can you move your arm? Just the thought of moving an extremity, mostly upper extremity, this pattern disappears. But it's going to last, you will continue to see it when the patient closes their eyes. Benign epileptiform transients of sleep. So this, I feel it's quite an oxymoronic kind of a name, right? So they are benign, they are epileptiform, they are transients in sleep. So they are sharp transients of sleep. It has multiple names. Benign sporadic sleep spikes, small sharp spikes. This pattern is the most abundant pattern out there among the benign variants. Most confusing, one of the most confusing benign pattern. It's usually seen in adults and rarely in children. This pattern is of very short duration, like 50 milliseconds. It's low in amplitude. What makes it confusing is it occasionally appears with a slow wave, an after slow wave. Temporal region during stage 1 sleep. This pattern do not disrupt background activity. So while you are reading this description, it gives you an idea. So if you have that idea that 1 through 6, what calls it a spike or a sharp? So you go through the description of a pattern, it gives you a mental map, right? If you are categorizing it as epileptic or not. So it is either independent or it is bilateral. So here is another example. So if you look at it, this is on the mostly temporal. You have an average you have a reference montage with the temporal leads here, and here is a bipolar montage. So there is a steep descending slope of this spike, and there is a tiny slow wave after slow wave with this pattern. This is seen during drowsiness and sleep. Okay, so this is a spike. There is a slow wave after that. It is happening in temporal region. So we all know that 70% of people diagnosed with epilepsy have temporal lobe epilepsy. So seeing them in temporal channels, it makes us question, is this a temporal lobe spikes and sharps? Until 1990s, they were considered epileptogenic. And suddenly in 1991, a study appears which says that, oh no, these are benign, small spikes and sharps during sleep. They are not epileptogenic. And from 2018, there are a couple of publications which are talking about depth recordings of the hippocampus. And so the spikes which are recorded from the depth recording from the hippocampus, and there's time-locked spikes from the scalp EEG. So is there a correlation between them? It hasn't been established, but the idea is these spikes could be an early indicator of hippocampal pathology. Until that is established, this pattern is still considered as benign. Keep an eye on it. If the patient is having some sort of clinical changes happening when you're seeing those spikes, then of course it needs further investigation. But if they are happening during drowsy state on the temporal, they are small spikes and sharps, and there are no clinical features, I think it's easy, it's safe to say that to move on and consider it as a benign pattern. So that is not an epileptic one. So this article from 2022 talks about normal variants. They have, I think, close to, if I'm correct, close to 300 patients. They are comparing, they are tabulating, I should say, different patterns in those EEGs and correlating it with their diagnosis. So BETs, or these benign small sharp spikes, if you see, most of the patients are either normal, there is no abnormality, and there are some patients with focal epilepsy. There are a couple of patients who have cerebral disorders. But like I said, so far, all the guidelines point this pattern is benign. Wicked spikes. Again, a pattern that is usually seen in the temporal region. This pattern is not only sharply contoured, but it is rhythmic too, lasting only up to 1 second. The frequency range is theta and alpha. This is an arch-shaped, arcuate-shaped pattern. It is not associated with epilepsy, but it is seen in patients who have cerebrovascular diseases, vertigo, headache, dizziness, and even migraines. So again, it is present in the temporal region. So how do we know it is not epileptic? One, their arch shape. There is no slow wave after that. And if you look at it, this pattern is not disrupting the background. The background remains almost the same, alpha, theta. So that gives us an idea. These are benign variants. So what is it? Clinical correlation. So there is no abnormality seen, mostly seen in normal patients or patients with cerebrovascular disorders. 6 Hz spike and wave. They used to be called phantom spike and wave. These waveforms, they have mitten shape appearance. They have a very tiny spike and a high voltage, high amplitude after going slow wave. So this appears to be like basically a mitten, right? They are mostly seen in young adults when they are relaxed, drowsy, and even during REM sleep. There is no definite abnormality seen in patients, in the EEGs of patients where wicked spikes were seen. But if you remember, these wicked spikes come in 2 forms based on their distribution, fold and VAM. Last time I read this when I wrote my EEG boards, and then this time I read when I was making this presentation. So it still exists, even latest articles that are publishing benign variants, they're still talking about it. So fold, which is seen in female in the posterior head region, is a non-epileptic pattern, which we just saw in this image here. So in a posterior channels, mitten shape appearance, theta alpha frequencies, not theta, I should say theta frequencies. Then there is another pattern, which is not so benign actually, which is called VAM, seen in men when they are awake, high amplitude compared to the one which we saw in female patients, and it is present anteriorly. So in the frontal head region, basically you are seeing 6 Hz spike and wave discharges. Now these discharges, they do overlap with generalized atypical spike and wave patterns. So if there is a repetition of this pattern happening in a patient who does have faintest chance of epilepsy or had epilepsy. So this pattern is going to be something that needed to be investigated. So here is an example: moderate to high amplitude, maximal over the frontal region. Still, it has mitten shape. That means there is a tiny spike and a large wave, but in the frontal region, it's a questionable epileptiform pattern. 14 and 6 hertz. So 14 hertz, we know that is a frequency of spindles. So 6 hertz we just talked about, right? So is these tiny 14 hertz could be rhythmic sharply contoured activity, which points towards it could be spindles, and then we have 6 hertz. And we just discussed what the 6 hertz spikes look like. So this pattern, its old name is tenoids, that in Greek it translates to comb. Because of the 14 hertz spike, it looks like, 14 hertz rhythmic spikes looks like a teeth of a comb. That's why the name. So these are only 1 to 2 second bursts, and they come in a frequency of 14 hertz or 6 hertz, or they come together. So if you are seeing 6 hertz, I would suggest that you look for any spindle kind of activity closer to them. And then you can say, okay, the patient has 14 and 6 hertz. If you're seeing some spindles and then there's a 6 hertz activity next to it, so that definitely kind of tell you that, okay, these are 14 and 6 hertz positive spikes. They're in the posterior quadrant when the patient is drowsy, and they are not associated with epilepsy risk. So here is a clinical correlation. Most of the patient either had no abnormality or they were normal EEGs, but there were few patients with focal epilepsy. And it is categorized as a benign variant. The rhythmic theta bursts of drowsiness. This is a rhythmic pattern. It is not a spike or a sharp like the one we just discussed, but this pattern is sharply contoured. And these rhythmic bursts, again, on the temporal, there is always a questionable thought in our head, right? Oh my God, it's a temporal pattern. It could be real. So this is a psychomotor variant. Why? We don't call it psychomotor variant anymore because this pattern was associated, it had similarities with the discharges during psychomotor seizures. That is the focal temporal lobe seizures. That's the reason it was named psychomotor variant. We are not using it anymore. It's like mostly RMTD or RMMTD. 4 to 7 hertz for a few seconds or few minutes. It can be brief. It can run for up to 20, 30, 40 seconds. During drowsiness, it's seen only in the temporal region, mostly mid-temporal. So it's a mesial temporal lobe pattern. So how do we know this is not epileptic? Because this pattern does not evolve. It is monorhythmic, monomorphic. It's going to look mundane. It's going to look all the same through and through, whether it lasts for 2 seconds or lasts for 20, 30, or 40 seconds. So it should not be confused as ictal rhythmic discharges on the temporal lobe, brief ictal discharges. It should not be confused with bursts. Okay, here is another example. So clinical correlation, mostly normal, and there is no definite abnormality in the patients. This is a pattern that's most confusing till date to me. That is subclinical rhythmic electrographic discharges in adults. As a monitoring tech, I have approached a physician saying that the patient has bursts. So I have to go back and forth to make sure before I contact the doctor while I'm monitoring to make sure that it is not epileptic. This is the most confusing pattern because they are rhythmic and they look so real when you see them. And we don't see them that often because it's the rarest of the rarest pattern in the list of benign variants. So only 0.04 to 0.07% of the EEGs show this pattern. Monomorphic, it is diffuse, sharply contoured, and a frequency range of 5 to 7 hertz in the parietal and the posterior temporal regions. So atypical strata may evolve. So what we talked about is that's a typical strata, right? Atypical may evolve only from delta to theta. But thing is, it evolves in this much frequency range, but when it comes to its distribution, it does not spread. It's not going to go spread throughout the head. That is a takeaway point here in defining if it is epileptic or non-epileptic. So here are a few of the tips to learn about it, right? Like, okay, this is not an epileptic pattern. So it shows minimal changes in frequency, morphology, and distribution. So morphology remains the same and it does not spread. Now, it is seen in patients when they're awake or drowsy and their consciousness is preserved. So if you are testing their response or something like that, you see that pattern and you ask the patient question, they're fully oriented. So relative lack of evolution on frequency and distribution, it's spreading to the other areas, and the background remains pretty consistent. There is no postictal slowing, which kind of gives an idea, okay, those were not bursts and that was not a seizure. This pattern, another hint is look at patient's history. If the patient is having any of these conditions that are described here, so there are chances that it's Schroeder. Still a confusing pattern after all that list. So here it is. Abruptly, it starts in theta frequencies in temporal and parietal region. Nowhere else you are seeing it. Whew. Okay, those were benign variants. So let's get out of benign variants and talk a little bit something else. What about sleep patterns? Do they look sharp and spiky sometimes? How many times vortex waves during sleep are marked as axis, or they're marked as sharp transients? So vortex waves are definitely sharp. K complexes are also sharp, but they are of longer duration compared to vortex waves. K complexes appear with arousal, with sleep spindles, or without sleep spindles. Same as vortex waves. So these can be a little bit confusing if you have runs of vortex waves. In children and in younger adults, you see multiple vortex waves in one epoch. So that make you question, are those the sharp transients or these are sleep patterns? K complexes in patients with genetic generalized epilepsies are abnormal. So these patients will show K complexes which are intermixed with spikes and sharps. So it's a very distinct EEG abnormality. With the microarousals, you will see K complexes. And if the pattern is appearing focally, usually it is a generalized epilepsy, right? So you will see spikes and sharps mixed with K complexes. So here is an example. So you see a very broad waveform, high voltage with sleep spindles. But before that, there are these small spikes. So this pattern is called dysrhythmia. These are epileptic K complexes. So this is not a normal pattern. This is an epileptic pattern. So a K complex without this spike and sharp is normal. So let's look at the K complex here. So this is what a normal morphology of a K complex is. If you look at here, these are blunted, broad-based discharges. during sleep, which are very much normal. And if you compare this with the waveform I just showed you, you can clearly see a spike before K complex is formed. And this is epileptic. I have seen this happening. You have to pay attention to paper speed. A paper speed can make your alpha and beta frequencies look like rhythmic sharps. So if some patient has mixed frequencies, theta, delta, with alpha and beta frequencies intermixed in that, and your paper speed is 10 millimeter per second. So you can see these waveforms will appear as if there are some rhythmic sharps happening. So pay attention to the settings of the machine before you call something a sharp or a spike or transients. What about patients with epilepsy and the variants? Is there anything different than healthy population, healthy patients, normal EEG and EEG variants versus patients with epilepsy and EEG variants? Is there anything that kind of stands out? No. We all know that epilepsy does affect sleep patterns. A patient with focal epilepsy may not show sleep architecture in the area, in the region where they have epileptogenic zone. But this paper says that there is no increase in benign variants in the epilepsy group. However, the benign variants were more diversified in non-epilepsy group. So there is no significant difference between epilepsy and non-epilepsy group, but the non-epilepsy group does have more frequent and diversified benign variants. It doesn't have this finding does not have any clinical significance. How about ICU? So the reason I put this slide together is because when you read at the right bottom, this is a screenshot from the 2021 terminology. So defining BERDS, they talk about benign variants. So what are they trying to tell us? What idea is it behind using the term benign variants when we are defining BERDS? So benign variants should not be included when you are defining BERDS, basically. So does it mean the benign variants are different? Do they have different significance when you see them in critical care patients or in ICU? So I went into PubMed and did some searching, benign epileptiform variant in ICU or in critical care, benign spike wave in critical care, it should be ICU. So I did these searches to see if there's any difference between the normal population having normal healthy individuals or patients with epilepsy having benign variants versus patients who are comatose, intubated, sedated, they having benign variants in ICU. So I could not find anything. So it may hold some different significance since it is mentioned in the terminology when we are defining BERDS. So I hope there is something brewing out there. Okay. Any questions so far before we go into our polls?
Yeah, we do have one question in the QA section of how else would you confirm that something benign and not subclinical?
Something benign is not subclinical.
How do you, like, I've been thinking, how do you confirm that what you're seeing is a benign waveform and not epileptiform?
Okay, so first thing that will come in my head is that 6 criteria out there, right? So in those 6 criteria, I'm going to see if this pattern is standing, like it's really standing out, right, from the background. That's where my eyes are going. And does it have a slow wave going after that? Before or after that particular pattern happened, was there any change in the background? What is patient doing? Yeah, Maria, specifically SERDA, yes, absolutely. So like what I said, so what I do when I am monitoring and I see some pattern like that, what I see is it getting spread? Okay, so if it is not going to if it comes for 2 or 3 seconds, you can easily call it that, okay, it's a benign variant. But if it runs for 10 seconds, that's when your brain starts to get fried, right? You're thinking, oh my God, did I miss an event? Did I not report it? So at that time, you have to see, did it evolve? If it is staying in the same frequency range, there is no evolution, its morphology is not changing, and it is not spreading to the other channels. So it kind of screams for a benign variant. I hope I answered that question. Are we good? I think Nawalge is asking dysrhythmia, how it appears and what it is. So dysrhythmia are patients with genetic generalized epilepsy like JME or childhood absence or juvenile absence epilepsy, eyelid myoclonia epilepsy. Those patients, when they sleep, their K complexes are mixed with epileptiform discharges. So they will have a spike mixed with epileptiform, mixed with K complexes. Okay, I think we can go with pulse, Brad.
Yep. So there's one more question from Abdullah. Should we mention benign variants in an EEG report?
Yes. That's what I showed in the beginning, very beginning, that they went through 283 EEGs. That means not just the EEGs, but the reports too, right? Nowhere they're mentioning that the patient was having a benign variant. So that means, are they ignoring it, or they did not consider it worth reporting? Did they completely forgot to mention, or maybe those were something which required further investigation? Yes. So if we are mentioning patient's reactivity, patient's background, with eye opening, eye closing, and EMG artifact and things like that, I guess yes, benign variants need to be reported, because down the lane, if there is something, you need to go back and re-review the EEG. Okay, this is what you marked at that time. You go back. So then there is interpersonal and intrapersonal differences in reading the EEG. So something you marked as a sharp or a spike, and then suddenly you think, oh no, that's a benign variant. And it could be reversed too. You mark it as 6 Hertz spike wave discharges, but then you go back and see those were real. Those were not benign variants based on XYZ. I like that, Maria. Okay, Brad, we can open the poll.
Okay. All right. So we're trying out something new using polls. You should just be able to click around where the chat is on the sidebar, and they should show up, but I can't see your view. So respond in the chat if it's not working. All right. Should be ready to go, Navita.
Okay. All right, looking at this picture here, what do you think it is? Is it interictal discharge or benign EEG variant? Use the rule of 6.
think we'll try to give, like 15 to 30 seconds for each of these, and then I'll end the poll.
Yep.
All right, we'll be closing the poll in 3, 2, 1, end.
Okay, those 9% people, I want you to go back to those 6 criteria we have. So these are the sharp transients. These are not epileptic. This is a benign variant, so 90% of you are correct. There is no slow wave afterwards. They are not disrupting the background. If you see, it still remains in alpha frequencies. There is no change in the background. And the field is very is not indicating anything of a normal thing happening here. All right, next one. Go ahead, Brad.
Yep. All right, poll is closed. So those are your results, Navita.
Yep, so 7% still think it's a benign variant. If you look at this waveform here, it is standing out. There is a slow wave afterwards. It is focal. It's unihemispheric with a mild spread to the other side. It is right-sided, sporadic sharps. So these are interictal discharges. Okay, slide number 56. I think we can close the poll, Brad.
It's hopping around right now.
Oh, yeah, it is. Huh. One, if you think it's interictal. 2, if you think it's benign pattern.
Oh, we're really right in the middle here. All right, a few more seconds. Oh, ended with 50-50.
So the biggest confusion here is, are these 6 Hertz spike wave discharges? Right? That is the biggest confusion among the audience here. I'm just gonna, so 6 Hertz spike wave discharges versus epileptiform discharges. So if you look at the size of a spike wave here, spike, it does not appear like a metal basically. The voltage of your slow wave and your spike. So it's a spike and a wave. 1, 2, 3, 4. If you see, these are not 6 Hertz. You have 6 Hertz of background, but your spike wave is not 6 Hertz. So this is epileptiform discharges. You have a spike, you have a wave. It is disrupting the background. It is not in the posterior channels. 6 Hertz spike waves are in the posterior channels. It's not VAM, which we said it is in the frontal channels, high voltage. These are not high voltage waveforms. So these are interictal discharges, atypical spike wave discharges on the right side. All right, so 50-50. Let's change the montage to see if it is reproducible. I wish I could. This is just a clip from a paper, right, from the article. Yeah, F4. F4 is the focus for this. Okay. We can move, Brad. We can go ahead on the next one.
All right.
Oh,
Good to go.
I have to move.
Yeah, I
have to move.
You're up next. All right, poll is closed.
All right, so 92% are absolutely right. These are rhythmic mid-temporal discharges of drowsiness. If you see, this is your left temporal here. Still, it's with temporal, right? It's here, another temporal chain, the red chain here, temporal, and it is both left and right side. So this is a RMTD. It's a benign variant. Temporal theta discharges. Okay, next.
All right, close the poll. You can go ahead, Navita.
All right, so this 12% around, these are interictal discharges. The first takeaway thing is it's hyperventilation. So these are the spike wave discharges because of hyperventilation. So that was the biggest cheat sheet. We don't even have to go into the 6 criteria from IFCN. Okay, if we are going to that criteria, the duration of the waveform, the morphology, how it stands out, and there is a slow wave going after that. And the focus is right posterior quadrant. So this is interictal discharges, 1 to 2 hertz, caused by hyperventilation. Okay, where the arrow is, we're talking about the pattern corresponding to the arrow.
All right, poll is ended.
Okay, here I can see the confusion. I can understand the confusion. This is sporadic, disrupting the background. So it could be interictal discharge, and there is a slow wave going after that. Other thing what you have to see is the slow wave is going only in one channel, T7, P7, right? And if you see these spike, it has a sudden ascent and a sudden descent. That usually is not the case with epileptiform discharges. So they suddenly rise and then they slowly fall. Or they can rise slowly and fall quickly, and then there's a slow wave after that. So these are, if you see, it is only on the right, on the left temporal and parietal So there is no field on the right side. So this is sharp transients, asymmetric sharp transient. We'll put X mark here or question mark, yes, but this is a benign variant. I know, it's confusing. But the reason is there is a slow wave with overriding frequencies here, which shows that the background is not getting disrupted. If this was a smooth, slow wave after the spike, you can consider it left temporal parietal spike wave discharge. But if you see your slow wave is overriding with faster frequencies or whatever the frequencies of the background are. So this is sharp transient, a non-epileptic from sharp transient. Okay. Moment of truth.
All right.
This 93% people are right. This is dyshormia. These are your epileptic K complexes. So you have this which looks like spike wave. There are some spindles happening. So you have a spike and you have this broad one, which you can call spike wave, but since this is an EEG during sleep, so you have K complexes with epileptic discharges in them. So this is abnormal. This is IID. I think that's it. Oh, one more. Okay.
All right, and polls over.
I'm happy to see Anderson said dyshormia for the previous one and spike on K. That's nice. Good to hear that. Okay, yes, this is 14 and 6 hertz. So mostly you can see 14 hertz. I had difficulty finding 6 hertz in this, but the description says 14 and 6 hertz. But yes, this is a benign variant 14 hertz spikes. I'm not seeing 6 hertz. If others are seeing, you have good eye. I appreciate that. All right, moving on. I think there's one more after that, I guess.
All right, and poll is closed.
Okay, so 63% thinks it's benign variant and 36% thinks it's interictal discharges. So if you see the distribution of this pattern, it is frontally predominant and it is 6 hertz. So these are 6 hertz spike and wave. This is VAM. So this would be considered, I would mark it as VAM and let the physician decide if they are calling it interictal discharges or benign variants. But I would call it calls further investigation. So this is 6 hertz benign variant, but it is in the frontally predominant channel, so it is VAM. I think I should have put history here, a male patient. Okay, I think one last one.
Looks like we finally found consensus on the very last one. Look at that, 0.
Yep. Yes.
We're going to go ahead and end this one.
We can end this one. So this is something, when I was doing my rotation when I was in EG school, I was told that eye opening, eye closing is a reactivity. And I could never find anything except one patient throughout 7-8 years I worked in the hospital. This, if you see, these are epileptiform discharges when patient closes their eyes. Yes, these are interictal discharges with eyes closed. Okay, I guess that's all I have. If you have any questions, please feel free to put it in the chat.
We do have one question asking the difference between atypical and typical spike discharge for absence.
Okay, that's the duration. So typical is 3 hertz, and then you have 2.5 hertz, 4.5 hertz, depending on type of epilepsy. So that makes them atypical. Either they are slow or they are faster. So typical is 3 hertz. 3 hertz spike wave discharges is our typical.
Then can we go back to the 6 markers slide?
Okay. A little slow. Go to slides. Where are my slides? Okay, it will take me at least.
Yeah, I don't think there's a way of clicking back to an individual slide. You have to just keep going.
Is there a home button like we can go to very beginning of the slide?
Yeah, I wish.
Okay. 6 hertz. This is our TV. 14 and 6. Almost there. Okay, so here we are. What's the question?
You have like 4 or 5 more slides back, I think.
Oh.
I think it's about the 6 markers.
Oh, the 6 markers. Oh, I'm sorry. I thought 6 hertz. Okay, that was very beginning, right?
Yeah. Like slide 15, 14, and 15.
What happened? Almost there. All right, here we are. What's the question, Brad?
It was just to ask to go back to this slide. I'm not sure if there's a specific question about it.
Okay.
And then for those asking questions about CEUs and having this presentation later, in about an hour, you'll receive an email from Webinar Jam that'll have a link to the replay, and it'll also have a link to the post-webinar survey. You have to fill out the survey in order to get the CEU, because then we submit everything to whoever Navita submits it to. And
to ASET.
It's to ASET, okay. And yeah, you'll be able to watch the replay, which will have this slide presentation.
Yes, so please provide your ASET ID when you submit the form, the feedback form. Nazal Punjani has a question. He says that they saw a patient with typical absence, but they were responsive during the ictal event. They called her name and patient responded. So those typical absence, if they are shorter than 10 seconds, like 1 or 2 or 3 seconds, patients do respond. Those are generalized seizures, but if they are of shorter duration, they do have lapses in time. But if those seizures are of shorter duration, patients can respond.
And I've also learned on that topic that a lot of those patients, they have absence seizures so frequently that are so brief that they're used to kind of not realizing they've missed a few seconds, and so they almost act as if they've heard what's going on just because they only missed about a second and a half of a conversation, and so they're used to just kind of picking up where they left off, and so it's not always evident that they were in fact technically unconscious.
Yeah, that's true. And
there's also a question: why do abnormalities decrease in REM sleep?
it's somehow the way brain generates those waveforms. So usually during the transition from wake to sleep, like during the drowsy period, that's when the abnormalities heightened up. But during the REM, it's the generation of those signals. See, REM EEG looks like wake EEG, except we don't have EMG. We have eye movements, and the background, the waveforms during REM has similar frequencies as if the patient is awake. So it's all about generation of those signals, those patterns. Mark, there are no epileptic discharges during REM sleep. That is something I guess I need to read more about that. But I understand that what I understand, it's a generation of those patterns, the part of the brain that generates the EEG during that time.
I don't see any more questions, so I think that's everyone. Just if you have anything left, just go ahead and ask.
Thanks, Brad.
Yeah, I think we're going to close out then. Thanks everyone for coming.
Have a good night, everyone.